Now I would like to turn things over to Terry Hill, Senior Advisor for Rural Health Leadership and Policy at the Center, to introduce today's speaker and to kick us off.
Thank you very much, Kaylee. And I guess it's still good morning, everyone. This is the second in a series of webinars we're putting together, really addressing the COVID-19 crisis. Last month, I hope many of you were on to talk about telehealth. We've seen a dramatic expansion of telehealth. And this week's topic is going to be on financial sustainability. We have 2 more webinars coming up in subsequent months, and Kaylee is going to tell you a little bit more about them at the end. But the National Rural Health Resource Center, for those of you that may not be familiar with us, is a national organization that's been in existence. We've been basically the technical assistance center for rural hospitals since pretty much the turn of the century. It's been about 20 years, actually. I've been working with rural hospitals for about 30, and I do refer you, if you don't know much about us, rather than me going on and on, you can go to ruralcenter.org, and we have just a ton of resources and materials, some of them developed by our speaker for today. Ralph Llewellyn is a partner with Bailey firm. He's just an extraordinary resource. Gosh, I think Ralph and I have worked together for at least, it's been close to 20 years. And he is not only an excellent consultant, but kind of a national leader in financial thought, financial work, et cetera. He's one of the people that we have a few kind of expert consultants that we really trust on this, because we work in all states in the country. And when we have financial questions coming in, Ralph's one of our go-to people. Ralph is also the person that we kind of impose on to do a lot of education for us, both in person when we hold workshops and conferences, and also in events like this webinar. So I recommend him highly, and I think the topic today is one that we all are very concerned about, kind of the financial sustainability of our rural hospitals and rural clinics are at the top of our priority list. And I'm going to turn things over now to Ralph. And I do encourage you, if you have questions, to ask them. Either you can unmute your microphone, or you can put them into the chat box while Ralph is talking, and Keely will be able to tell us about whatever the questions are. So with that, and thank you for being here. Oh, I should also say the funding has been made available through the Nebraska Office of Rural Health, which I'm sure you folks are familiar with. And that funding originally came from the Federal Office of Rural Health Policy and the Medicare Flex program. So Ralph, I will turn things over to you, and then we'll have a discussion afterwards.
All right. Well, thank you especially for the kind words. Terry and I have had the opportunity to get to work together and travel together once in a while, and I greatly appreciate that relationship and the ability to assist them when possible. So when we talk about this topic today, financial sustainability for rural hospitals during the COVID crisis, definitely, when I think about what's happened in the last several months, our worlds have been turned upside down. And I think if we would have thought back 3 or 4 months, we would have thought our worlds were pretty much already upside down with what was going on in rural healthcare and a lot of the closures we've seen. So it's just some new challenges in different places. So a couple of things here. When we think about the challenges that are out there now, just unprecedented. I mean, just the reduction in non-essential procedures. And the one thing I will say is we work across the country, as Terry indicated, that really varies. Some states maybe have not been hit as much. And I would probably put a yet behind that, because I think some of the states that we work in just haven't even really seen what they really are going to see as impact in the long run. And we're starting to see some of that as as states are trying to reopen, or as the summer months come and people are trying to get out a little bit more, we're going to see some of that. You know, we have this potential influx of sick people that we're trying to figure out how we're going to deal with. I've been really fortunate to be part of a team in North Dakota where we got called in at the very beginning to talk about, you know, how are we going to handle all of this from, did we know how many beds were in every facility, not just licensed, but available to be opened? And even if they were available, did they have staff to do that? And at that point in time, when everything was going crazy initially in Washington State with some of the nursing homes and in New York, we had everybody panicking about what happens if that happens in our state. You know, do we have enough beds? Are they in the right spot? Where are we going to set up extra beds? We actually did have extra beds set up in a couple of locations just to see how would they set up the quote temporary hospital and stuff. We're past that, but you know, there's just that whole, how are we going to deal with that? And then we got these unanticipated costs, types of costs that we haven't incurred in the past, causing us to rethink how we operate today, how are we going to operate in the future? And you get to this point and it's, you know, what's a real provider to do? Well, I know the first thing that, you know, came up when all this started to happen was all the calls we were getting about how am I going to handle this? I've got X days of cash on hand. And for many providers, it wasn't much above a couple digits. And, you know, it doesn't take much there when you're already fragile. We've already seen the slides of all the hospitals that have closed since 2010 and how vulnerable and how much of a challenge we have from just staying open under a normal situation. Now we've got this whole new thing out there. And the initial part is we got to make sure we're getting dollars and cents because I'm not going to have enough cash to get me through a few days. And so we're going to talk about some of the funding sources that I want to make sure everybody's aware of, make sure people understand the obligations that come with some of that. The one thing I will say though, is that while we were scared to death about having cash, now some of us, depending on your facilities, are on the other end of what in the world do I do with all this cash? Because some facilities have, I have a facility that I work with between PPP and the HHS funds, they've got about $1.2 million, $1.3 million in cash. So they're a smaller provider. Their annual budget's $1.2 million. And they're trying to figure out how do I document all this? What am I going to do with all this cash? Now I've got some bigger facilities. I work with some CAHs that have over 100 million in net revenue. They're still kind of struggling, and because the cash wasn't as much as far as a percentage. But let's talk about some of the funding sources, because fortunately they have been available, and fortunately totally unprecedented. They actually got money to us quickly. And it was probably the first time I can ever remember in my 30 years of being in healthcare that CMS wasn't holding up the process of getting cash to us. HHS, while they still have money to give out, they did get some of that money out pretty quick. That's just unheard of when we think about things. So again, a lot of cash, a lot of significant funds out there for some providers. Doesn't mean it's going to be enough for everything, but it's a lot more than I think we thought was going to happen initially. So that's some of the good news that's out there. So I'm going to walk through kind of some of the various pieces that are out there because there is a lot of cash that's been flowing and people just need to understand the pieces of it. The one thing I want to make sure everybody is really aware of, you know, is initially some of the funds are saying, oh, this is getting all released and there's no strings attached. There are typically strings attached, and this is no different. You know, goes back to what my mom told me when I was growing up, nothing is free. There is always something there. I have providers sometimes saying, well, I want some money that I don't have all these obligations around everything. It's like, well, there isn't any of that. Everything that we receive has some sort of string attached, something that's pulling us back to say we've got to do some reporting, we've got to track some information, etc. And that's where some of our concerns are, because a lot of our providers are doing a lot of work to make sure they're getting this all documented, but there's another group in camp out there that are, yeah, you know, I'm just not getting to that. That's not that important. They're not going to come take the money. They said they're not going to come take the money. Well, they kind of said that, but they also said there's still hooks. So we got to be careful there. So advance payments. These are the accelerated advance payments that you could get from the Medicare cost report. Repayment was required. This was a huge piece initially to get some cash in everybody's hands with the idea that at a certain point in time, you would start having that recouped from your payments. So it's not a gift, it's not a grant. You're going to have to repay it over a certain timeline that has been set up, or there'll be some implications as interest and all of that, which the interest rate was very high. Now, we've seen a lot of push and a lot of discussion out there by various groups about, gee, will this be forgiven? And, a lot of discussions. I would say the discussions that you hear are pretty much not from any official entities. They're from trade groups, they're from hospital associations, they're from providers and things like that. I have not seen anything coming from CMS, anything coming from anybody in Congress that's bought off on this. Probably just because this one would be a big financial bullet to swallow. And I'm not sure how that would work. And I think there's another group out there that's saying, wait a minute, we didn't go get that money. And so others did go get that money. And so you're going to forgive the ones that got it, but not the ones that didn't know it was going to be forgiven. So there's a lot of pieces there. Our recommendation at this point in time is, while we're still working with associations and things like that to see if there's any traction in that area, you probably want to proceed with the idea that that's going to be repaid. If you can figure out how to make things work financially with that having to be recouped and repaid, if it changes, you're just going to be that much further ahead. Payroll protection. These are the forgivable loans. This was kind of a great program for a lot of providers. Those of you that are tied to governmental entities, I know there was a lot of struggles at the very beginning about, do they qualify? Do they not qualify? We were fortunate. We were working with some legal counsel. We were getting them qualified from the very beginning, but a lot of them were really delayed in being able to get that funding until the second wave, because by the time they were getting indication that it was allowable from the SBA and everything, which, by the way, NRHA did a great job of really being the advocate there. Maggie Elawani is amazing at her ability to push. And so when we got that clarification, everybody was jumping on that in the second wave. So that covers a lot of things: payroll, interest on mortgage, rents, utilities. The biggest piece here is documenting it, making sure you're getting your documentation. The rules keep changing on this one. As far as, how many weeks, because it was 8 weeks, now it's 14 weeks. When do you have to apply? Or 24 weeks, sorry. And all of that there. So this is just one to keep watching, but most providers that we've been dealing with are now in a situation where they think that this is going to be a pretty good, easy slam dunk as getting this taken care of and covered and forgiven. One thing to keep in mind with this one, because we've been watching conversations with the various MACs, so WPS, NGS, Noridian and others, as well as CMS, about how is this forgiveness going to be handled on the cost report. And so I did a session a couple weeks ago with Kansas Hospital Association. Somebody from WPS was on that one. Really didn't have any, they were confused about what the program was like. So they really didn't have good guidance. Initially thought, oh no, it wouldn't be. Maury heard about it. He's like, yeah, that probably is an offset, but never really came out with any clarification. They've received nothing from CMS on this at all yet. And there has been nothing official from CMS to any of the MACs that we've been able to find through our discussions about this topic. But we have gotten some scuttle that there is going to be something coming out from CMS that's probably going to say that this is going to be offset on the cost report. So nothing official, but if I was in the C-suite of a hospital, I would be looking at my financials, both what does it look like if this is not have to be offset on the cost report? What's it look like if it has to be offset on the cost report? so that you and the C-suite as well as the board at least understand what that unknown factor is, where that risk is. So something just to keep in mind as you monitor and watch that funding area. Employee retention credit. This is for people that did not get into PPP. So this allows some refundable tax credits equal to 50% of qualified wages on the first 10,000 of wages. So you get a credit of up to 5,000. And it's got the requirements here. You know, you had to fully or partially suspend operations due to an appropriate government authority or experience significant decline in gross receipts. Most of the providers I've been working with were able to tie into the PPP funds, unless they were tied with a large system or something that disqualified them from size, then this might have been a factor that they were looking at. SHIP funding, this is the small rural hospitals located in the United States and territories with hospitals of 49 beds or less. This funding is ranging by state. It varies a little bit. It's mostly about between $80,000 and $85,000 a facility. It's supposed to be used on COVID-related items, so there's going to be some requirements there to be able to document that that's what you spent it on. Provider relief funding. And so this is where that big bucket is. And there's still, you know, a significant amount of dollars still sitting out there that'll be eventually given out. Some people are like, well, why don't they give all of it out right away? Well, some of it was set to be distributed to those that had high impact or were highly impacted by COVID with a large number of cases. Well, if you'd have released it all initially, New York would have gotten all the money in the whole country and there'd have been nothing left for everybody else as it's spread across. So they've been moving this out in waves on some of that high impact dollars. The conversation on the cost reports in this area has been nothing from CMS at this point. So not even no scuttle coming out of CMS. The session that I did in Kansas, the conversation with that one is that that individual that was presenting, who is the head of their audit, I believe, for WPS, said that the directions to their auditors was that this was would fall under grant funding. And as such, the rules do not require grants to be offset. So that's their position at this point in time, with the caveat that CMS could come out with additional guidance that would contradict that and change that. But at least that's where we're at there. On this area, this is another area that's kind of similar to PPP. If I was in the C-suite, I'd be looking at what's that range of potential cash flow impact if it ends up having to be offset. Especially since this would be, usually substantially larger number for a lot of providers than what they got in the PPP dollars and cents. So know that there's a lot of us that have been asking for a lot of clarity on this on the cost reports all the way back to late March, early April when the funds started coming out. It's just waiting to get information from CMS. And with that, we did hear that the information that will come out from CMS will be most likely like in the form of like an internal memo to the provider or to the MACs. Those are not the types of things that are typically shared. So our question has been, is this going to be something that is going to be disseminated to all the providers? Unfortunately, they said they didn't think so. And we're pushing back on that and going to be trying to work with NRHA and others to force CMS to have to let providers know what their position is. Because our take on it is how can we hold you accountable? How can they hold you accountable? And how can we help guide people if they have no idea what the rules are that are going to be applied? So that's just another piece that we've been pushing on and looking at. So provider relief funding, these are the areas that most of the rural providers have seen their money come through. There's the 50 million, it was in those two pieces. 30 million of the first part, 20 million in the second. The 30 million was sent out quickly just to get cash in everybody's hand. When they gave out the 20, then they went back and looked at their methodology for the whole 50 and then reconciled it. So it basically is supposed to come out to 2% of your provider's net patient revenue. There was the $10 billion rural allocation. That was a significant portion for a lot of providers. I've seen some of those numbers up there in the 4 or 5 million with a couple of providers that I work with. That was a big chunk for some. But with a minimum of $1 million for a CAH, what a nice at least dump into the bucket. The 4.9 billion was the nursing home allocation. So that was some additional dollars that came out. There's been a 500 million tribal allocation out of there. There's the uninsured allocation where you actually can submit claim information on those patients that you had that came in that were related to COVID and were uninsured. And then there's a $15 billion Medicaid, it should say Medicaid there, sorry, allocation for those not qualifying for the 50 billion allocation. So these are those that typically take care of just Medicaid type of patients, not Medicare. And so that's a little dump in the bucket there for them. We've got the other funding sources. There's the FCC telehealth. I've got a few providers that are looking at doing that to increase the ability to do telehealth. I've got a few providers that have applied. It seems like I'm wondering if that process has gotten bogged down with the number of applications, because I've had some providers that have had applications in there for a while. And they're supposed to be processing them as they go. So I've got providers that are starting to check on just kind of the state of where that's at. ASPR state grants, $50 billion were allocated, with some of it allocated to each hospital association. They didn't each get 50 billion, it's 50 billion across. The grants I've seen there are typically in that probably $5,000, $6,000, $7,000 for some of the rural providers. And then there's FEMA. FEMA is the one that, initially we had all the providers running after saying, oh, I'm gonna go get FEMA funding. And that's really a last resort. So with all these other things that have been coming in, people are trying to get that funding in and trying to document kind of where they're at with being able to document the expenses and everything else and lost revenues. So this now takes us into what's the cost of the fund? Back to that, nothing is free, nothing is there. So the one commonality is that you have to look at tracking. And so every facility, if they haven't been doing it, should be tracking their lost revenues for the HHS funds. You need to be tracking your additional expenses, tracking specific expenses if a grant has specific items that they're looking for. So the things that we want, recommend you look at there, tracking of lost revenues. The frequently asked questions out from HHS would say, you can compare it to average monthly revenues. You could look at it against prior years. You could look at budget. We've actually worked with a lot of providers using a tool that does more of a projection methodology based on historic. The problem with prior years is it doesn't take into account any inflationary factors. Looking at budget, I have a lot of providers that either are conservative in their budget. So if you have conservative budgets, you've basically understated your ability to report some lost revenues, or providers that just spread their revenue and expenses over 12 months rather than actually trying to get it down to month by month. In those situations, you might be hurting yourself from what you can track. So look at your options there. In the area of additional expenses, I tell providers here to really step back and be creative in what you're thinking about in this area. I have providers that are, doing basic things like PPE, maybe lab equipment for testing. But I've got other providers that are starting to look outside that, like, are we set with our negative pressure systems? Are we, our negative pressure capabilities where they should be? Do we have to have separate areas for people that come in that are potentially infected with COVID? And so how would we, what does that mean from a building and a structure and things like that? People are looking at ventilators, should they be getting that? People that are looking at automated systems to do the testing at the door, little kiosks that have iPad type situations where it can take your temperature, have you answer the questions, give you the green light to be able to move in, and proceed into the facility. Lab specimen collection sites. You know, as we have more and more people looking at telehealth, which is the other thing people are looking at, how do they expand their telehealth to make sure that it's adequate. You know, right now, a lot of people just threw together what they needed, but now they're saying, should I make it more robust? But then if I have my patients outside and they need to have lab and they still have to come inside the hospital for the lab, did I defeat the purpose of the telehealth visit? So now should we be looking at lab collection sites, you know? And in some of the conversations we've had is it's almost like, do you have a garage? Looks like almost like a car wash type thing where you drive in one side, you drive in, you come in, they can come out and do your lab draw without you having to, you know, leave and get inside the facility, and then you drive off. I know a lot of people are using tents and curbside and stuff like that. That works out maybe in June. Is that going to work in December? You know, we start thinking outside that box. You know, obviously it all has to be related to COVID, but there are definitely a lot of things to think about, and think about how are you going to prepare yourself to take care of the patients that you need to now. But what if we have that spike in December? Or what if it comes back next year? Or what, you know, and I'm even thinking about, we know the flu is going to come back because it always does. A lot of these capabilities we're putting in here will also protect our patients at that point in time. So it's really trying to be wise stewards of how do we invest that into our community, not spending money just to spend money, because I know some of you on here are former CFOs like me, and you know, we were taught to hold on to every piece of cash from the very beginning. Here we're trying to figure out how do we justify it so we don't lose it on the other side. So the one thing I would say is there's definitely a significant amount of time being spent by a lot of providers to start tracking. There are some tools out there that people have put together to help track things, allocate it between the various programs, between PPP, HHS, ASPR, FEMA, all those things. The one thing I would say is you want to get your documentation and ducks in order, because we are going to see audits here. There's just way too much money for there not to be audits. And then I do believe that it's HHS's intent to not to recoup funds, but they're also going to be held accountable to make sure the funds got used in the manner that the attestations indicated. So we're definitely going to just kind of want to watch that side of it. So that kind of takes the funding side to that point. Maybe just a quick, is there any questions to this point before I move into the next spot? Might be just a good spot for a break in questions.
You can either unmute your line with the unmute button in the lower left corner of your screen, or type them into the chat box and I can read them off.
I just have a comment, Ralph. It's just, you know, the PPP being offset, as you well know, could amount to significant, basically, repayment of those funds. And in my mind, it kind of goes against what they were trying to do with the program to start with. But
we would totally concur with you, and that's been the pushback that we've had. You know, it's kind of similar to, you know, the tax treatment of it for those that are taxable entities, where they're saying, no, we're not going to make you count that as income because that's kind of against what the intent was. So we're going to try to use some of that argument, but that might take legislative action to do that. Now, the one thing to keep in mind, and I'm not trying to minimize the impact here, but it's not going to be a dollar for dollar take back. We're still going to come out ahead, but we agree with you that it's still not the intent. We do not think it was the intent of Congress to funnel some money into the programs here or in HHS, only for Medicare to take it and put it back in their bank.
yeah.
So, but that's the challenge, because that's not the CMS mentality. So that's our challenge. So do know that us, as well as some of our counterparts in the industry that do the same things as we do, there are several of us firms that, you know, probably talk a lot more than people realize to say, are we all on the same page fighting the same battles for you guys? And that's kind of where our challenges are.
Yeah, no, I agree. Those actual numbers are going to be important when they when they say you have $1 million, that $750,000 might go back, or, I mean, it might wake some people up. Thanks.
Exactly. Nope, not a problem. And if anybody, between now and the end of the session too, if you have specifics about, hey, I was wondering about this kind of an expense, would that be, something that we think would qualify or not? That's great conversation, because from there we can talk about, well, maybe it doesn't here, but what if you did this, or what if you did that? That's probably been half of my week each week for the last month, is calls with individual providers about, I want to do this, what do you think? Or I've got a part of my facility that wants to do this, and somebody's arguing it's part of COVID, and we can start having conversation about, well, how do we document that? Does it really? I had one facility the other day that was looking to add a CT machine. I'm like, well, help me understand, how are you going to diagnose or treat COVID patients in your facility with that? Are you going to use it to diagnose? And I'm not the clinical person, so I can't tell you if you can use that to diagnose, but everything I've seen so far, it's lab equipment. So are you going to treat them? Well, yeah, we could treat a patient that's here. Well, are you going to keep any of those patients? Well, no, we'd never keep any of those. Well, those are the kinds of questions you'd get asked in an audit. And so it's starting to think that through. A facility that's going to keep the patients and they're going to use it as treatment, now I've got an argument. That's why I need, an adequate, CT scan. But that's a facility by facility conversation. So with that, go ahead,
just a quick question. I've heard some speculation that maybe instead of forgiving the loans, they would simply reduce the percentages, maybe down to 2% was the figure I heard. Have you heard anything of that nature?
Oh, are you thinking on the accelerated payments for the cost reports?
Yep.
Yep. I have seen more conversation on that. I think that, because I think the normal interest rate would be 10 point some odd % interest on that amount. And there has definitely been some conversation at reducing that down to something more like the going rate of 2-3%. That one I think has a much better chance of getting some legs behind it. But we're trying to go after both angles, but we're really focusing on, gee, if there'd be a way to get some of it forgiven. I think that one's going to be a bigger uphill battle though.
Yep. Thanks.
Nope, that's a great question. So short term, you got to start looking at your short to mid-term cash flow planning. A lot of this money came in, but now you got to start figuring out, okay, as I extend this out, if it goes out until December or if it goes out until the middle of next year, what's my cash spend and at what point do I start to run out? For some facilities, that's going to be still relatively quick in the realm of things. For some of my smaller facilities that got dollars and cents that were a much larger, substantial portion of their budgets, theirs might be a much further out time period. We don't know how long we're going to have to report costs, because they don't say, you have to expend your costs by this period for HHS. We anticipate on expenses, when the emergency goes away, they'll probably start to put some clause around that. From a lost revenue perspective, we would argue that there's probably going to be lost revenues above and beyond the time period of the emergency, because there are going to be some people that are going to continue to avoid things in the hospital, that if they can avoid them temporarily. So we'll be continue to push that. And then I think what we really got to be doing as for providers is starting to look at, the temporary and permanent organizational changes. So if you've got a rural health clinic, we've changed the way we can do telehealth. We know that there's things that we've changed as far as where patients can come in and have maybe some of their blood drawn and things like that there to be safer. I think what we have to look at now is, how do we take this opportunity to look at what are the long-term implications of this? And it may not be that the long-term implications are the rules and the loss of the waivers, but I think we have to start thinking about what's going to change in the mindset of my patient. How are they going to act differently than what they've done in the past? What's their expectation change going to be? And so when I think about that, it's really going back again and looking at what is temporary and then what is or should be permanent. Things like telehealth. You know, when we think about telehealth and that, you know, we've got waivers on it for billing right now and for coverage. And then there's some licensure waivers. But what of these, which of these should and could be permanent? So now we can start talking to congressional leaders, because we already had Secretary Verma say, you know, the genie is out of the bottle with telehealth. Now we got to figure out, how do we make sure that everything is in the language of the law? Because even if the genie's out of the bottle, if the law says thou shalt not do that, which is what we've ran into with the RHC piece of being a distant provider, we still got to get the rules changed. So now we got to start thinking about, how do we work with that? How do we work with Congress and others to do that? But then let's say that that is only a temporary change and we can't change that distance site. Because you know, since I'm talking to Nebraska facilities, I know a lot of you have rural health clinics, and you've all been told prior to the pandemic, thou shalt not be the distance site for telehealth. You cannot, will not, shall not, everything. And so what a lot of people heard is that as a facility, I can't do distant site. And that's not what was said. What was said is you can't do that in your RHC. But you could have RHC providers that have certain days of the week or such that they're not scheduled in the RHC and they're over in the hospital, because the hospital can be a distant site. And we start thinking about, how do we set things up so that we can work within what the rules are? Thinking outside the box, doing things a little different. Now, my preference would be is you could do it in the RHC. My preference would be is that they count it as an RHC visit, so they don't pay you just the $92, and that they would pay you based on the all-inclusive rate. But I might not get my way with that. And so I got to start thinking about, what are my alternatives of ways to do that? Because I do believe that our patients, and a lot of them are ones that we would have thought before all of this would have said, I'm not interested in telehealth. I can tell you a lot of them, including your seniors, are now saying, this works. I was talking to a provider the other day. They actually have patients that have said, after all of this goes away, I plan on continuing to use this methodology. You know, some of them are snowbirds. You think about that right now, your snowbirds, they leave, they go down, you know, south in the winter and they use their providers there. They're saying, now I might be able to retain that patient throughout the whole year. Now, some of that might come into a situation of, will CMS allow us to reach out that far to do telehealth? Because obviously they're not going to want an RHC, you know, providing telehealth services, getting cost-based reimbursement for patients that live in Omaha, because that would be outside the intent of what RHC is there for. But those are the kinds of things we got to start thinking about, is how does all this change? What equipment do I need? Equipment, which, by the way, could be funded through the HHS funds that I got to find my documentation for. Again, not wanting to spend money just to spend money, but if I have something I have to document or lose it, here's a great opportunity to start looking at those things. Am I going to have, you know, people at the front door forever checking conditions to make sure that people that are coming in aren't sick? You know, then do I start looking at the technology that goes around that? Lab, you know, equipment and things like that for, you know, obtaining specimens. You just got to start thinking about all of that. I have some facilities are saying, I'm going to need to add an ambulance bay. Or not an ambulance, but an ER bay, because one room isn't enough, because I don't, you know, if I have one that's contaminated, I've got to figure out how I'm going to handle that. So there's just a lot of things there. The other thing, yeah.
Ralph, could I just jump in? Because I think this point is so important here. I just want to underline it or bold it or whatever. I was talking with one of the medical directors for United Healthcare, and they were talking about the data that they're seeing right now. So they had like 250 telehealth consultations, medical procedures, just telehealth services provided. They were basically saying, on a 5-point scale, we were getting 4.8 and 4.9 scores. 4.8 in terms of satisfaction on the part of the patients, 4.9 in terms of satisfaction with their physician on those telehealth visits as well. And she pretty much said, that's where we're moving. You know, it's very clear, whatever CMS does, we're moving to tele-urgent care. The second piece had to do with, well, what about physician acceptance? And she indicated that they had gone from physicians, like in February, 22% of the physicians had done telehealth procedures, but 2 months later, that was over 75%. And that the feedback from physicians was that they really liked it as well. So I think those barriers that were there before, which I think were really pretty significant, have been largely overcome. And that's not to mention telemental health, which takes stigma, a lot of the stigma concerns out of it, particularly in rural areas as well. So I just wanted to emphasize that, because as rural hospitals, we've got to be thinking about our next steps in this particular area.
Absolutely. And there are, it's interesting when you talk about like all of the mental health, behavioral health, all those pieces. I actually on my desk here have a portable little gadget with an iPad that I'm testing out from a vendor that does that kind of service, where they basically can bring in and pop on a little kiosk in any room of your clinic, any of your hospital, your nursing home, and the remote provider can call in. They can actually tilt the screen so they can see the room and see the patient without somebody else having to move it. The technology is just so cool right now, and lots of opportunity there. And the acceptance, yesterday, one of my calls, we were asking about the providers and how well they accepted it. And they said, even the ones that were really pushing back on it in the beginning have all adopted it. And some of them have indicated that this definitely is the way of the future now that they've seen it. It didn't mean it worked the first time just exactly the way they wanted, but when they had to keep repeating it because it was their only option, they figured out the problems and the nuances and have really figured out how they're going to make it work. My mom never would have done a telehealth visit before this. Through all of this here, she had surgery, major back surgeries, rods, things like that, nursing home stay, all of that. That was on the 15th of March approximately. She had her first face-to-face visit with a physician on Thursday of last week. She's done all of her other visits from her home, telehealth. The only problem we ran into is that she did have to have some lab done. So she did have to go into the clinic to have the lab drawn, which goes back to that whole piece of how are we going to handle that in the long run? Because that's the only little flaw we've seen in the whole system. And when I talked to her last week about the issue, she said, I plan on doing all my visits that way that I possibly can in the future. In the winter, I don't have to worry about, is it going to be icy? Is it, is it going to be too cold? All that. I'll just have my visit and I'll be off and running. So and she would have never done that before. Never. So, and she's a tough patient. So, I mean, that was encouraging from that perspective. Reopening. Reopening is a big deal. So a lot of facilities now starting to say, how are we going to reopen our services for those things that we had to shut down because of volumes and concerns. You got a couple of things there. One is the safety side. So people are kind of going slow as they're opening them up. Day one is not back open full because it's not as easy as just turning the switch back on. Some of these have been, closed up for a few months. Takes a little time just to make sure you've got everything in order and up and running. But the other thing is that if you're doing that, how much pent-up demand do you have? Because if there's, in some of our markets, we know that there have been a lot of services pushed off. And as they're reopening, everyone's trying to schedule. And as everyone's trying to schedule, some of our providers are saying, we're going to actually work to try to expand our access by doing extended hours for a time period to try to catch up. Now, in your facility, that may or may not work. You may have some staff that were getting reduced hours overall this time period and will gladly jump on top of this and say, hey, here's a way for me to recoup some of it. It's a good way for you guys to recoup, you know, some of the volumes and things. But if you were one that were strapped tight with staff, they might be saying, I'm already wore out. So how are we going to deal with those kinds of pieces? And the thing is that if you're not going to deal with a surge, if that's an issue in your market, what are you going to do if your competitor does? Because that is a great way for a competitor to say, hey, we know you can't get this elsewhere, but we're here for you. You know, some people are going to take advantage of that. So the whole ongoing fear, I've already talked about that a little bit. Really pounding hard on these telehealth, virtual visits, and e-visits. I mean, Terry hit it. It's just the way it is. This is a game changer, and this is going to change the way that as we start thinking about how do we build clinics and structure our clinics, and how many rooms do we need per provider, and what kind of staff do we need by provider. This is going to change all of that. In 10 years, a clinic is not going to look like it does today. You know, I can tell you with some of these virtual visits, our staff have the capability to actually use some of these virtual type visits through our carrier, and have for a while. And what they've done is, I had one staff person, she was on a vacation, and kid was complaining about something with his ear, and they pulled over on the side of the road and made the little phone call with the to the app and got it scheduled, had the little visit on the roadside, and by the time they got to the next town, the script was already there and waiting for them to continue down the road. Our staff, that's a huge satisfier. Yes.
Jen is asking, any thoughts on being able to use CARES Act funds for costs related to converting to a new EHR? Our current system has a lot of functionality and is going to end of life in 2021. A new system would promote continuity of care for transfers, telehealth, etc.
Boy. So when I get asked these questions, the first thing I do is try to figure out how to say yes. But what I got to go back to here is, what is it about COVID that caused this? What happened in the way we care or are going to need to care for patients in the future that has changed this? The fact that the system is going away, it doesn't have the functionality, that in its own doesn't give me a lot of comfort in that. And I tell people, you know, it's not that you need to convince me. You need to convince somebody who's got a federal badge and is saying, explain this to me. Because ultimately, that's the only person you really have to explain it to. And if we start to feel uncomfortable with that conversation, which is usually where my conversations with people that are trying to push things outside the boundaries stop, because they're like, yeah, we'll pass. Okay. I'd need more information of how are we going to tie this to the fact that it's related to the diagnosis, treatment, and the situation of COVID. So I'm not going to say no, but I'm a lot closer there because I don't have enough facts to say I've got something I can grab onto. I want to say yes, though. It's just how do we document that? And I think that that's going to be a stretch. But I'm not the official either. Okay. So changes in patient communication, that's going to happen. You know, I'm seeing some of these, actually the tool that I was looking at for the telehealth, that actually will help notify people of their appointments and everything that's going on if you don't have that capability. But we're going to be changing the way we communicate with them, how our facilities flow, our facility need, you know, that clinic, what does it look like in the future? Definitely a big change. So with this, we also need to know that our competition is going to take advantage of telehealth. You know, and our competition isn't our local competition. The big cities are going to be saying, oh, I can tie all my telehealth providers into all these local communities, and I can take all the business away. I can get all the visits directly, all the primary care, all of that. And when they need tests, I'll just send them, you know, up our way to have them because I'm not going to order them at the hospital there. So that's one of our risks. Excuse me. On the flip side, I think this is also our opportunity to expand our footprint because we need to start saying, how can I push out to communities where maybe people don't drive into my community because it's a little further distance, but maybe I have the providers they like, and by using telehealth, I can attract them. And when they have to come in for that occasional visit, they are going to come my way. But how do I use that to push out my footprint? And I would even say that if you're starting to get into insurers that are going to cover this, is how do I, if I am, you know, if I'm Jim Frank and I'm saying, hey, how do I expand my service line? How do I do this so that I'm actually advertising and being able to get patients from Omaha that are going to use my provider? Maybe I have a specialist that, you know, has, you know, some capacity or something. How do I start reaching out? Or maybe I've contracted to do some of these virtual visits for a company because those are the ones that, you know, maybe aren't as complex, but they'd be volume. You know, how do I keep my providers busier? Sometimes we have a base of providers that one could say we're overstaffed for the number of visits we have, but we have to cover ER. We got to cover these other things. Well, who says I can't be part of a contract to do virtual visits for, you know, a payer contract? So I can keep my providers busy. I can better afford to keep them on because I have to have them, but I can make it a different financial picture. So a lot of things to think about as you look at how do I expand my service base using telehealth while pushing away from that risk of somebody else trying to steal my business. So with that, I'd open it up to questions.
Ralph, I've got a question in terms of the change in the payer mix. One of the things I think we're concerned about is as our patients are in financial decline in many cases, their inability to pay, so the danger of rising bad debt expense as well. So any thoughts on that?
You know, it's definitely a risk. We have not heard very specific pieces where people are seeing that yet. I think that's going to be probably more of a market by market situation. You know, the fact that the PPP funds were out there and other, you know, aspects of keeping businesses open for the most part, that has helped, I think, shield some things in that arena. And it might be more shielded in our rural communities than maybe it is in some of the bigger cities, because a lot of the layoffs that I've heard about are the, you know, large number of businesses that are basically closed down tend to be in more of our urban areas that I've seen anyway. But that I haven't seen the huge influx of bad debt yet. It's still kind of early though. Mm-hmm. The one thing to keep in mind is that if they don't have insurance, you know, there is that uninsured fund. And that one is one of those that as soon as the money runs out, it runs out. So if you've got those cases, you're going to want to get those running through, but they have to be uninsured. It's not going to take care of that copay, deductible, you know, that part of it. I do see there's a question here. Our RHC is located 20 miles from our hospital, lab, etc. We're expanding COVID testing at our primary location, but in order to use CARES Act RHC funding that was intended for the expansion of testing, we will need to do it at the physical RHC location, correct? Or at the very least within the specific community that the RHC is located. That's an interesting question. I'm not sure you would actually have to be able to perform the test, you know, in the facility there. I do think that being able to say that you're going to have to do it for the patients of that RHC or that community, that makes sense. So if you're looking at buying a piece of equipment that you're going to put in at the hospital, that's going to do all of it, just this RHC and the others, we'd probably need to look a little deeper as to how we're going to allocate that cost. because I'm sure someone's going to say that that's not all RHC. The one thing that we've been trying to get some clarification on is, do these funds, like there's the SNF funds and all of that, do all of them need to be allocated specifically into just that one bucket? Or is it for the overall tax ID that they've got to be spent in that range? So I'd watch for maybe future clarifications on that on the HHS websites. We're obviously advocating that you should be able to look at it in the more global of how do you expend it at the tax ID number, but that is an open item right now.
Ralph, we've basically hired you to help us put together a new document for our National Rural Health Resource Center for our Medicare Flex program, which is basically going to deal with a lot of the issues you've talked about today. Could you talk a little bit more about that? And my understanding is that's going to be due out relatively shortly.
Right. So this is a document that will be housed with the center, and the draft is actually in Tracy's hands. That was sent on Friday. I believe she's out through today on vacation or PTO or something. So she has the draft. We'll be waiting for some feedback there. The goal is going to be to have it out. I think they're going to try to do it by the end of the month, is kind of the role. And what that'll do is it'll lay out each of the various funding opportunities and lay out what type of entity it applies to. Is it an RHC, a CAH, a rural provider, FQHC, etc. It'll do that for all the major funds. It'll have links to the various rules and frequently asked questions and all of that. It'll have discussion about the general, who is eligible, what are the reporting requirements. Right now, I think it's I think the way that we laid it out, first of all, it's like a 60 or 70 page document, but it's very much like a PowerPoint presentation from the visual. So it's hopefully an easy read, but it'll have all of the hyperlinks to get you out to those sites. And we will be updating that as things change through the end of August and keeping that up. It's interesting with the updates. We'll be doing updates up to every 2 weeks. Not planning on doing them more often than that. Just because the one thing we have found through all of these things is that you could be updating every few minutes. I had this draft ready 3 times, ready to send it, and just as I was getting ready to send it, something new came out, so we tried to get that updated before we sent it to Tracy for review. And I think, well, I don't know, there's a new interim rule coming out on PPP, I believe, today. So there'll be an update to that before it even comes out the first time.
Yeah. And we're excited about putting something like that together because it will be constant, a frequently updated resource. The information when it comes out will then be distributed to the Nebraska Office of Rural Health. So look for something probably from Nancy Johansson when we have this together. And again, it's going to be relatively soon. We'll probably have to get the final approval from the Federal Office of Rural Health Policy, but that should be available shortly. And hopefully it's going to be a really useful resource. Kind of with that, we're running out of time here. I really want to thank Ralph. This has just been an excellent presentation. I know I've learned a bunch. I could ask him another dozen questions here, but I do so appreciate you being a part of this. Keely, we have, this is the second part of a 4-part series that's funded by the Nebraska Office of Rural Health. Could you tell me the next 2 that are coming up?
Yep, so our next one will be coming up on July 14th with speaker Lee Elliott, and the topic is ensuring staff availability and resiliency in a time of crisis. And then our 4th and final webinar is on August 11th with speaker Louise Bride on the topic of protecting our older and most vulnerable hospital patients.
Yeah, we're gonna focus in on staff, the well-being of staff, etc. Some of you may know Lee Elliot, he's a Nebraska person, and so I'm excited to hear what he's going to be saying. And then Louise Bride is with the Stroudwater Group, and she's an extraordinary resource. We didn't have time to follow through on some of this funding for skilled nursing facilities and long-term care, but it's obviously a point of concern given the incidence of COVID-19 at the deaths and long-term care facilities. So with that, I'm going to say one final time, thanks to Ralph, and thanks to all of you for being a part of this presentation and webinar. Take care, everyone.
Thank
Bye-bye.
you.